Good evening, everyone. Welcome today for a very special session on our ongoing CVD Prevention series, live from DEBAKEY Cardiovascular Disease Studio at Houston Methodist. While heart disease and related conditions such as strokes still remain the leading cause of morbidity and mortality, as a preventive cardiologist, it truly gives me an immense pleasure to note that just over the last 3 decades, we have witnessed significant reduction in both of these outcomes from cardiovascular disease. And now, what is less recognized that at least half of this, what we have achieved, is really in terms of improvement outcomes related to greater access, procedures, processes of care, but also I think so there's been a role of better medication, mostly in the realm of controlling lipids, blood pressure, and reducing thrombotic complication. Now, the holy grail remains who is at risk and why they're at risk. I think so that's where we have lagged, where our insights on the mechanistic approaches on the pathophysiology, its determinant, be it biologic, genetic, social, environmental, towards either increasing vulnerability or even resilience remains poorly understood. At the same time, I think so we also celebrate that as a biomedical enterprise, we have made great advances in diagnostic imaging, biomarkers, genetics, new therapies, lifestyle. And as a preventive cardiology, allowing more earlier, more accurate, and I would say a precise management of patients at risk of wide range of the spectrum of cardiovascular disease. In an era, of course, we are seeing a rich with significant advancement of understanding of early development, progression, complication. There remains tremendous choices in how do you risk stratify? And more importantly, are we maturing from our older pathways? What we have seen in the path of precision medicine, there are goals of treating the right patient, right time with the right therapy. I feel in general preventive cardiology, we have lagged behind and still remains in silos where focusing on laws of averages, be it lipids, genetics, risk factors, and considering everyone is at the same level, for example, those with diabetes, severe hyperlipidemia, or even absence of them. Now, many years ago, I was extremely fortunate to work very closely with a dear friend, mentor, and a colleague who challenged me and all of us, specifically asking us to step back and maybe ask a more fundamental question. What if we are thinking about this maybe is in the wrong context? And rather than focusing on the silos, how can we integrate them for better preventive care? Not only for treating, but managing these patients, but applying the same concept for a more patient-centric research, unlocking the various mysteries of why people develop disease and how does it progress. So for this, I want to introduce today our special guest from Miami, who have spent the last 3 decades or more trying to address these issues. Dr. Arthur Agatston himself, who needs no introduction, gave us the first peek into the non-invasive insights of the foundational disease in cardiovascular medicine, that is chronic atherosclerotic disease, in 1990, and later led a major revolution on optimal diet via his South Beach program. Remains an inspiration for us and continues to be curious, and rather dismissing experiences which challenge our conventional dogma in clinical medicine, he has been pursuing those difficult issues, generating new knowledge, asking us to think more. And so I'm very delighted that he'll be sharing his experience and pearls of wisdom with us that he's collected over so many years managing these complex patients. So Arthur, it's a true honor having you on board today, and we look forward to an exciting discussion.
Thank you so much, Khurram, and it's a true honor to be with you. And for the audience, I often describe Dr. Nasir as my fountain of youth, who when he came to Miami and worked with me really stimulated. I learned certainly as much from him as he might have from me. And my experience today, he had told me wonderful things about Methodist, but meeting some of my heroes, Dr. Gatto and Dr. Bill Zogby, was such a pleasure. But the overall culture of Methodist, I'm just blown away with. And so this was just a wonderful experience. And I hope really to continue to collaborate in very productive ways. And after seeing everything up close and personal, I'm confident we can do that. As Khurram mentioned, integrating many silos of prevention has been, I think, really, really important. If we look at silos of prevention, it started with lipidology, genomics more recently, diabetology, imaging, heart vessels, liver, pancreas, even in the brain, hippocampus, nutrition, fitness, and behavior medicine as well. And sometimes I feel like a jack of all trades, but a master of none, because I have learned so much from masters in all these areas. But my, my frustration is often they're not talking to each other and not putting all their knowledge together for prevention in the individual patient. And that's why it's such a pleasure to be here, where I see Methodist and Khurram really leading the role to begin to bring these silos together. Now, our approach in Miami, in individual patients that I see, which are usually high-risk patients, come to me because they have a bad family history of heart disease, they had a heart attack at a young age, and a high calcium score, and trying to figure out the cause and stop the progression. We now start with a measure of total atherosclerotic burden, or the calcium score, and something new recently, looking and quantifying insulin resistance and beta cell dysfunction as part of what we call the Kraft test. And once we see that, then we try to explain what's happening, and listed here are a lot of the risk factors we look at. And on the right is what I describe as pre-diabetes, because if somebody's heading for to be diabetic later in life, you can measure differences even from their early 20s, as we'll see. And this I liken to sort of the soil, and most Americans have soil where the seeds, which are separate genetic risk factors, can grow. If you look at a society like the Maasai in sub-Saharan Africa, they have the same seeds, but they don't have the soil, they don't have the lifestyle, and they don't get coronary disease. And so on the right, and naturally, the soil, the pre-diabetes, there's genetic background, but most of us have some of that genetic background if it's turned on by the lifestyle. And in this country, in the West in general, let's see, when I put on the spot, it's not coming on. Well, let's just start from the top. We start with our bad diet increasing our insulin levels, insulin secretion. That turns glucose and fructose in the liver into fat. We start with a fatty liver, it overflows to the pancreas and to visceral fat. That's our abdominal obesity. It overflows into the bloodstream as triglycerides, a storage form of fat, and decreases our HDL, and this leads to small LDL and HDL particles, which are atherogenic. Also, high blood pressure, which is, we're realizing that what we always called essential hypertension is really due to high insulin levels, which causes salt retention and depresses nitric oxide levels. So increasing high blood pressure, renal dysfunction with age are really markers of insulin resistance and beta cell dysfunction. And all this occurs before you have an abnormal oral glucose tolerance test or an abnormal hemoglobin A1C, defined as 5.7 or 6.5 for diabetes. And of course, fitness, sleep, other lifestyle factors, chronic stress, all are important. And then on the left side, are the various seeds. And so something like Lp(a), which is a risk factor we've known about for many years and can increase substantially your risk of coronary disease. But if you don't have any soil, if you're, again, sub-Saharan Africa, Maasai, without any what I call pre-diabetes, it's not going to matter. But once you have some fertile soil, then the high Lp(a) can take hold, and that's where we see people with a large atherosclerotic burden. And to show you an example of a patient who was actually seen by a preventive cardiologist who, going by guidelines, by conventional guidelines, Framingham score, even A1C less than 5.7, despite his belly, he didn't appear to be at high risk. And in fact, he wasn't treated. And when he eventually had a CT, the fat on the outside reflected the visceral fat, which we could see below his diaphragm. So he was not treated. He had neither a calcium score nor the test for insulin resistance or beta cell dysfunction. So we began to understand this with advanced lipidology. And here we're looking at LDL, HDL size distribution, lipoprotein residence time, which is a new concept which I learned from Ron Krauss and from Robert Superco many years ago. And I have been using it in practice ever since. So normally, with normal metabolism, the liver makes small VLDL to get rid of some of its excess triglycerides and cholesterol. It's circulated to the body, dropped there off where it should be. As you lose triglycerides, you have a large LDL, which is not atherogenic and has a short residence time in the bloodstream. If you're eating the wrong foods, processed carbohydrates, sugar with a lot of fructose, you end up with de novo lipogenesis. That's the insulin turning the glucose and fructose into fat. The liver tries to get rid of it with large VLDL particles, which are slowly metabolized to VLDL remnants, to small and even very small LDL. This takes a while, and there's a longer residence time for all of these elements in the bloodstream. There, they get oxidized, they get glycinated, and that makes them sticky. They're eaten up by macrophages, scavenger receptors in the intima, and that's the beginning of atherosclerosis. And when it happens fast enough and there's enough of the small LDL, there are also cytokines which produces a lot of the inflammation that we see in atherosclerosis. And this is from the placebo arm of the Jupiter study, the study with rosuvastatin. And in fact, it shows when you have large LDL particles, the asterisk indicates statistically significant increased risk. Same when you get to small LDL particles, increased risk. And smaller are usually more risk, but the very small is usually congenital, although it's very atherogenic. And we see all of this in practice. So it's not the amount of LDL, it's the size of the LDL and the overall residence time. The longer the residence time of a lipoprotein, the more it gets oxidized, glycated, and the more it's attractive to macrophages in the intima. And this, in fact, shows residence time in people with different degrees of this pointer is still not working, but anyway, the top, as with the top, we have severe diabetes, even mild diabetes with a lot of small particles. The LDL hangs around longer, again, gets oxidized and glycated. On the bottom is normal with normal residence time, and the potentially atherosclerotic particles are cleared and they don't become atherogenic. And there are other times when you don't necessarily have small particles, but where LDL particles, even if normal size, are not cleared. And the best example is familial hypercholesterolemia, where you don't have enough receptors on the liver. As Brown and Goldstein show, you only have half the receptors. So even if you have normal size LDL, they have a long residence time. They're cleared more slowly. They again become oxidized, glycated, and become atherogenic. Now, with lifestyle, this is a typical patient we saw recently. Big belly, indicating there's visceral fat. It also means there is fat in the liver and the pancreas. These are measures of his small and medium LDL, the small LDL, and on the right is how we see it in LDL distribution, and the small particles are dominant. That means he's atherosclerotic. Now, here is another patient, Yeah, it's not good. Another patient who's obviously thin, doesn't look like the last fellow, and in the middle is his visceral fat, which he has very little. Yet, when we look to the LDL size distribution on the right, he still has small particles, and he actually has some very small particles. And in fact, he has a high calcium score, 558 at the age of 52. And this is congenital small LDL, and it's not actually been reported in big studies. We see it all the time. If you see small LDL, whether from lifestyle or congenital, it is atherogenic, and you see high calcium scores. Now, this is another phenomenon we've seen. Again, somebody who's long and lean, which is typical of this, we call HDL dysfunction. Now, normally, if you look at HDL distribution, you have large HDL particles and you have small HDL particles. And usually the large is a little bit less than the small, or about the same. But years ago, we found some patients with predominantly very large HDL, and what we call the HDL bump. That means the large HDL, which was thought of as protective as the good HDL, was not being cleared by the liver ultimately, and the mechanisms are still up for more research. But this is a very common finding. The total HDLs in these patients are often in the 90s or well above 100. If it's well above 100, this is very common. They have very high calcium scores, and the HDL, the so-called good the good cholesterol, is actually atherogenic because it's not being cleared. It's again becoming oxidized and glycated. So long residence time, this is atherogenic HDL. Now we're going to move to another topic which does overlap, which is a natural history of insulin resistance, beta cell dysfunction. Beta cell dysfunction and diabetes. And it was somebody relatively local, Dr. Ralph DeFranzo, who's one of the heroes of diabetes research. And he did a lot of clinical trials funded by the NIH, and he looked at insulin resistance, beta cell dysfunction with what we call glucose insulin clamp testing, and he discovered that beta cell failure, the cells in the pancreas producing insulin, that failure occurs much earlier in the natural history of type 2 diabetes than we ever realized, and is more severe than previously appreciated. And as you'll see, we can now measure that relatively easily without difficult intravenous tests. Now, he also found that at the time you have just impaired glucose tolerance, pre-diabetes, you're already maximally or near maximally insulin resistant. You've lost about 80% of your beta cell mass and your beta cell function, and you actually have the beginning of microvascular disease, retinopathy, neuropathy, and nephropathy. And so the way it works is, if over your life you have a normal glucose as measured by hemoglobin A1C, and you're developing prediabetes, diabetes later in your 60s or 70s, that means that your insulin level, in this case postprandial insulin level, we measure it after the same glucose drink that you use for a glucose tolerance test, that you develop lower insulin levels and beta cell dysfunction very early in the game. So here's diabetes with an A1C of 6.5, and you have a lot of beta cell dysfunction, meaning low insulin levels by the time you reach that. But in fact, these people headed for diabetes in their 60s and 70s, if you look at them in their 20s, as they did at Yale, they already have insulin resistance. It's taking very high insulin levels to keep their blood glucoses or their A1Cs normal. And after a few years, they already have evidence of pancreatic beta cell dysfunction. And this is what Dr. Trafonso was talking about. This happens very early, and it happens in patients who are not yet overweight and with normal glucoses. So this is all running under the radar. So this is from Dr. Franzo in some of his clinical trials, and showing that when you have a measure of beta cell dysfunction, and it's calculated with insulin resistance, it's really a combination of both, that by the time you still have normal glucose tolerance, but if you do an oral glucose tolerance test, but when it's still normal, you've lost up to 50% of your beta cell function. By the time you're at the end, the last tertile of impaired glucose tolerance, you've lost better than 80% of your beta cell function, and then by the time you're diabetic, you're almost making no insulin at all. And so this starts early, and this is a study from Dr. Peterson and Schulman at Yale, where they looked at freshmen who were thin but had diabetes in the family on both sides. And when they gave them a meal that included carbs, their plasma glucose in the group with the family history versus those who were considered insulin sensitive without a family history, just looking at glucose tolerance, they overlap. But on the right, when you look at insulin levels, the insulin levels are much higher in the insulin resistant group, and it's taking these high levels of insulin to keep the blood sugar normal. And this is really new information. Now, the other important thing, and I think this is a great potential area for research at Methodist, is this is from Dr. Roy Taylor in Newcastle in England, the Counterpoint study, where with diet, patients lost weight, and he found with a 3-Tesla MRI magnet that their liver fat decreased substantially. And this has been replicated in many studies. So even in teenagers who are overweight, they already have a lot of liver fat, and if you take bad processed glucose and fructose away, the liver fat diminishes fast. But they also have pancreatic fat, much harder to see with MRI, but Dr. Taylor figured out how to see it with a 3 Tesla magnet, and also showed that pancreatic fat occurs early in insulin resistance and is associated with beta cell dysfunction, but you can decrease that pancreatic fat with lifestyle approaches. So if we're looking at insulin resistance and the natural history of it, and where we're beginning to gain weight, it turns out that the insulin resistance and beta cell dysfunction precedes and actually causes weight gain. But the weight gain does not cause the initial insulin resistance and pancreatic beta cell dysfunction. And what about A1C? If we're decreasing insulin production from beta cell because of beta cell dysfunction, the A1C should be going up much earlier before we arbitrarily say the A1C is abnormal at 5.7. And this was a study from Mass General. They looked at NHANES data, and they looked at so-called normal A1Cs between 4.9 and 5.6, not going up to 5.7, in normal individuals without known diabetes between age 40 and 70. In fact, the A1C is going up the whole time. And in fact, in the West, particularly in the United States, during this period of decreasing insulin production from beta cell dysfunction, your A1C is going up. And the question is, what's going on here? Is this pathologic before we arbitrarily draw that it starts becoming abnormal with an A1C of 5.7? And in fact, if we looked at large, apparently normal populations of ALT, fatty, which can reflect fatty liver, in fact, when your A1C is completely normal, the ALT starts to go up. It's still within normal limits, but this is indicating that fatty liver starts way before you're pre-diabetic or diabetic. And if you look at one of the best measures of small LDL triglyceride over HDL, again, this is going up with a general Western population years before you hit an A1C of 5.7. So in fact, this is another study. This is looking at atherosclerotic burden, largely with coronary calcium, and looking at A1C and the atherosclerotic burden. And in fact, again, the atherosclerotic burden starts going up before you hit the official threshold of prediabetes. So in fact, we have this large area that's below the radar, that in clinical practice with a so-called normal A1C, we're saying you're fine, goodbye and good luck. But in fact, obesity is starting here, and so is coronary calcium, is atherosclerosis, coronary artery disease, and other issues. And this is being missed in clinical practice today. And the question is, how do we find people in this missing area? So where do you stand on the diabetes, insulin resistance, beta cell dysfunction, plaque burden spectrum? And the answer we found is Kraft testing. And Dr. Kraft was a pathologist in the 1970s who, when they first were able to do immunoassays and studied insulin levels, he did actually the equivalent of glucose tolerance test with insulin. He went out to 5 hours, and he reported that most Americans didn't pass his test. Now, here is one of our typical patients, not quite typical, a guy, he actually lost weight and developed a completely normal Kraft test. So at baseline, where it's fasting, he had his fasting insulin level less than 5. Then you drink 75 grams of a glucose drink, same as with a glucose tolerance, and you measure insulin at 30 minutes, which is normal. Here between 30 and 35, it can go up to 40, 50, 60 and still be normal, and it comes back down to normal, below 5 in this case, at 2 hours. This is a normal Kraft test, and most Americans do not pass this. They have some degree of insulin resistance and beta cell dysfunction. Now, on the right here is a diabetic who had actually been a diabetic for 16 years. And compared to the normal, he starts with a higher than normal insulin, but it goes down initially. It doesn't go up at 30 minutes. And it stays low, it goes up gradually, and it peaks at 2 hours instead of hitting a trough at 2 hours. Now, we know there's severe beta cell dysfunction, as we saw. That's why his A1C is 7.4 instead of 5.2. And he still has insulin, he has insulin resistance, and he clearly has beta cell dysfunction. So this delay in insulin, lower levels, a delay in it getting up, and then it persists for hours after 120 minutes, which becomes very important in diagnosis and in our physiology. So here the diabetic is diabetic because really pancreatic cell failure, and you can see how low the insulin level is before you're finally diabetic. Now, we mentioned this happens early. I showed you the Yale study. These are people within our practice. Two 24-year-old, a BMI of 19, super thin, A1C of 4.9, which is actually high for a 24-year-old who is this thin. Now, both of her parents were diabetic, and already her fasting insulin is near normal, but she peaks instead of at 30 minutes, where she already has in insulin levels, it's high, over 120, but she peaks at 60 minutes with an insulin level of 140, and then comes down at 2 hours, still over 40, meaning beta cell dysfunction. Her beta cells have not recovered. So this is showing that insulin resistance, beta cell dysfunction happens before obesity, but it's a time when she has to start paying attention to it. The other patient is actually the stepson of one of our internists who noticed that he was developing a belly, which you really can't see here. It looks pretty thin. He's 23, his BMI is 21, completely normal, but he gained 5 pounds in his belly. He just finished college, it was COVID, drinking a little, some fast food, and his test showed again a delay in peak insulin, showing that's beta cell dysfunction, very high level of insulin, showing insulin resistance, and again, beta cell dysfunction. He wasn't coming back to even near normal at 2 hours. So in his case, and in both of these young people, they're back here at the beginning of beta cell dysfunction before there's any obesity. So this is all is pathology that's being missed by our traditional testing. Now, this is a patient with, although close, this is the first patient I showed with what I call pre-diabetes, because his A1C was 5.6. But to keep it there, he had to develop an insulin level of over 250, and at 2 hours it only came down to over still well over 150. And we convinced him to do the true Kraft 5-hour intolerance test to look for what was happening with his beta cell dysfunction. And in fact, the cause of obesity and diabetes, we now realize, is beta cell dysfunction that's persistent with continuous insulin elevation. So here he is, our traditional Kraft test, but going out to 5 hours, his insulin level is still high. It's about 40. Well, what does that mean? A 40 insulin level blocks you from accessing your own energy stores in between meals. So when your blood sugar falls, your insulin level is high, your lipolysis is blocked. So is glycogenolysis. So you can't break down your own energy stores, and you're looking for outside sources of energy. One of the best examples of this is hibernating bears. At the beginning of fall, their insulin levels naturally go up. They deplete the local forest of berries. They climb high trees. If you know people who live in bear country, they have to lock their garbage away because they found ways to open the garbage. They climb trees and attack bird feeders where there's sugar. They break into homes and the refrigerators. And they are putting on 600, 800 pounds of fat, yet they're still super hungry. That's because they have beta cell dysfunction, so when their blood sugars fall, they can't access that 600, 800 pounds of fat. They look for the outside sources, the berries or the local garbage. Now, once there's winter, they're not making enough berries, they're programmed to find their den and begin hibernating. Their insulin levels fall. They're not blocked from accessing their own fat. That's what they do during hibernation, and that's the survival mechanism. That's why we have insulin resistance and beta cell dysfunction. Now, most Americans, this is Dr. Panda's study. He's an expert on diurnal variation in glucose levels in insulin, and he developed this app called the Feedogram, where people keep track of everything they eat all day. And this was in a healthy population. And on the right, is the summary of all these Feedogram, and what it shows is Americans are what we call grazing. They are snacking around the clock and often in the middle of the night. And why? It's because their insulin levels are persisting high. They can't access their own fat levels. When I was growing up, I never heard of grazing. In fact, there are good studies. We were never snacking like we are now. But if you experience hypoglycemia because your blood sugar is falling and your insulin levels are too high, nothing is going to stand between you and the donut and getting your blood sugar up quickly. And that's what's causing obesity in the Western world. And so what we're seeing is up to a certain point, we're gaining some weight as you develop beta cell dysfunction, but once you hit persistent beta cell dysfunction, that's when you have prolonged elevated insulin, you're blocking lipolysis, and the weight really pours on. And so all this happens. You just have to look around the next time you're in an airport. Most Americans have hit this threshold, but they're not necessarily in A1C of 5.7. So we now look at this, and we look at this whole cardiovascular spectrum. We look at the images I've been showing you. We do it with something called the FIT3D. It tells us lean body mass versus fat mass, and it's really been very helpful in following trends in individual patients. When we do our calcium scores, we go below the diaphragm where you can see degree of visceral fat. On the left, none. On the right, a lot. And we see the spectrum of HDL, LDL size distribution. On the left, a lot of large particles, healthy, and then progressively small particles. Here, predominantly very small particles in a very high risk patient. And of course, we look at the spectrum for calcium testing and for Kraft testing. So looking at a few individual cases, this is first the patient we looked at. And here you can see he lost, I think it was 26 pounds of total weight, over 17 pounds of fat. He lost quite a bit of lean body mass. When you're not carrying around that front pack, there's less stress on your muscle and bones. You lose lean body mass unless you're doing resistance exercise. His percent body fat decreased a lot. And in fact, he started with pretty small LDL that shifted to the left. And as he got better, he actually developed the HDL bump. He unmasked the fact that he has HDL dysfunction as well. So you knew he was storing fat in his liver and his pancreas from his just looking at his belly, but in fact he was filled with visceral fat. The one thing he had initially was an inappropriately high HDL for somebody who's insulin resistant. Now they didn't know that because they didn't do the Kraft test and they didn't do a calcium score. And did I catch, I'm sorry, I missed so in fact he had severe insulin resistance, severe beta cell dysfunction, small LDL, and a high calcium score of 1200. So with that, and if we had had the Kraft test, we would have known all this, even though he didn't fit any national guideline criteria for aggressive management. So he's done very well with diet. Now with exercise, he's lost more weight, and he's on medication as well. And this was improvement in his Kraft testing, where the total insulin levels came down, meaning he's more insulin sensitive, and the 2-hour peak decreased, and he's now actually decreasing his 2-hour insulin level. So he's improved his beta cell function as well as his insulin resistance. Kraft explaining midnight snacks. This was actually a physician who was quite overweight, but without a high A1C. And he lost, it was 13 pounds, 10 pounds of fat, He lost a little lean body mass, but he was exercising some 3% of body fat. And in fact, he initially had an insulin level of 250 to keep his A1C again below that 5.7 threshold, but he also had a persistently high insulin levels, over 100. So in fact, in the middle of the night, he had high insulin levels. He tended to eat late at night. So when his blood sugar dropped, he was asleep, but his heart, his brain, his kidneys are still working. His blood pressure dropped, but he couldn't access his own fat stores and glycogen stores because of the high insulin levels. He woke up in the middle of the night, raided the refrigerator. He thought it was anxiety, certainly waking up with hypoglycemia. You're shaky, you feel anxious, and depression. But when he lost the weight and he improved his insulin resistance and his beta cell and his insulin came back almost to normal, he improved his beta cell function, his midnight snacks ended, and he realized it wasn't anxiety, depression, it was his beta cell dysfunction and his insulin resistance. And so he's more insulin sensitive and better beta cell dysfunction. And here's another young patient, visceral fat, age 37, bad family history of heart disease, high Lp(a), already has coronary calcium, and he's got a belly. And he went on a diet, lost, I can't see, about 30 pounds. Yeah, and lost quite a bit of fat, put on just a little visceral fat, big percentage. And in fact, he went from a very high insulin level, some beta cell dysfunction, to practically a completely normal Kraft test. And with that, he also lost a lot of the desire to snack. And here's his LDL and HDL size distributions. Interestingly, you can see this shift to the left. You can see his large particles increase, his small particles decrease with, in this case, a low-carb diet. And his HDL goes up, which also happens with low carb, and we realize he has HDL dysfunction as well. So he has high Lp(a) and HDL dysfunction with some beta cell dysfunction, but not that unusual for his age, but it's with those extra seeds that he has a calcium score in his mid-30s. Now, this the last slide I'll show. This is actually the father-in-law of one of our nutritionists who was near diabetic, A1C in the 6s. Before I saw him February of 2020, she started, he had already lost 11 pounds. His A1C was down to 5.3. And so here, his baseline weight was 154. He continued on the diet, very compliant patient, doing aerobic exercise, which was mainly walking. Came back in 4 months, lost 10 pounds of weight, but 5 pounds of fat mass, and he actually lost 5 pounds of lean body mass. So half of his loss was lean body mass. He lost about 2.5% body fat, but that's because if you're carrying around the backpack day and night, you increase your lean body mass. You're putting more stress on your muscle and bone. If you take away what I call the front pack, you're going to lose lean body mass. So we started him on a resistance training program the next summer. And then we saw him a little delayed because of COVID, and his weight went from 145.5 to 146. He's plateaued, he's not doing well. But when you look at his fat mass, he came down another 5 pounds, and he increased 5 pounds of lean body mass from resistance training. He lost even a greater percentage of body fat, and at 73, A1C had been in the 6s down to 4.9. And in fact, his Kraft test, his first one looked very much like a diabetic pattern, peaking at insulin levels at 2 hours. It came down dramatically and much less at 2 hours. So now he had many, many years of beta cell dysfunction, probably a lot of fatty pancreas, so his beta cell function takes much longer to come back. And I'm going to run through deconditioning. What we've learned with this Fit 3D is here's a guy with a pretty good looking Kraft test. He came back with a horrible looking Kraft test and said, well, this is my first Kraft test failure. What could have happened? It turned out he was chasing his grandson, broke his ankle, was in a cast, went off his diet, and in fact, this was deconditioning. And on this, he lost a lot of lean body mass while he gained fat mass and gained percent body fat. So this is deconditioning, very, very common. When we look at this, it's there on the Kraft testing on the Fit 3D. And so combining this has really helped us a lot. It's loads of fun, and mainly with the Kraft test, we're finding insulin resistance and beta cell dysfunction in all those years, which was under the radar. The only way you could find it was euglycemic clamp, essentially sending patients into the hospital for difficult intravenous studies. And so this is something we think that's going to spread. It's an easy test to do, and I think Khurram's going to start using it here. Thank you so much.
Wow, Arthur, this has been fantastic. You know, it just shows there's so much that more than that meet the eyes. And traditionally, if you look at what's happening, I would say in the general practices, or I would say the hobbyist preventive cardiology groups, is you do a 10-year risk and you look at your numbers and you look at the lipids and that's it and you're done. And you clearly show the whole spectrum, and you're actually pushing it much more further and saying even before insulin resistance, pre-insulin. But one thing that definitely intrigues me, and of course I've learned mainly from you, in the end, you've always found atherosclerosis measure as the integrator of the risk. And you say, well, sometimes there are going to be discrepancies and things that we don't understand. Why is that?
Well, we don't understand a lot. And in fact, until I learned actually from Ron Krauss that small LDL, which I was following as part of the atherogenic lipid profile, high triglycerides, low HDL, that some people, I thought it was actually a problem with their iron mobility, and this actually is not yet reported. A lot of thin patients like the one I show you have small LDL, and he has a high calcium score. It's congenital small LDL. I had no idea that a patient with high HDL, that HDL was actually atherogenic. But in all these, starting with the plaque burden, and it was a calcium score, without the calcium score, I would have said, well, you have a high HDL, you're safe. If there's some heart disease in the family, you're not going to get it. Your HDL is high. And it's adding, when with the Kraft test, I'm finding the reason. I see somebody coming in their 40s with a heart attack, and they're not diabetic. I have a patient at a time coming up like that, but they already have beta cell dysfunction, they have insulin resistance, and they have some of those seeds, even familial combined hyperlipidemia, high HDL, so many things that we're finding, spectrum of PCSK9 abnormalities in receptors, and we find reasons for more and more of the zebras now.
That's true.
And it's frankly, it's also, it's a blast going to work every day, because every new patient is a puzzle, and they tend to come to me with really high calcium scores, and usually now we can figure it out.
So Arthur, one of the key things we see patients, and actually there is a question from the audience, is I'm doing everything right, the diet, sleep, unable to lose weight, unable to get myself cardiometabolically healthy. How would a Kraft test help?
The Kraft tells, first of all, some people, we call it sometimes normal weight obesity, and you told me of a patient recently who are overweight and they have beautiful lipids. They will pass a Kraft test, and they have, it's unusual, they have a lot of subcutaneous fat but not visceral fat. They don't have fat in their liver, they don't have fat in their pancreas, and the good news is that they're really going to be, they have a good prognosis. The bad news, it's very hard for them cosmetically to lose weight. When you have the visceral fat, when you lower your insulin levels, you lose weight very easily. The problem is when you get carbs back in your diet, you can gain the weight easily. The good thing is the newer generations of the GLP-1 agonists, the HGLT2 antagonists, the pioglitazones, believe it or not, they actually help restore beta cell dysfunction. And so for those who really find the diet and exercise so challenging, the medications are excellent as well. And we're finding these people again much earlier, because if some are saying, I can't lose weight, and they said, I'm not diabetic or pre-diabetic, the Kraft test in fact shows they in fact have insulin resistance, beta cell dysfunction, and that may be why they're hungry all the time.
So Arthur, insulin levels become such more important, and a question from the audience is, you can have a normal insulin fasting, but can it be higher during the rest of the time?
Absolutely, and that's why we found you really have to do the complete Kraft test, and we do 2 hours because it gives us most of the answers. Kraft did 5 hours, and somehow to know how bad your beta cell dysfunction is and the potential to restore it, to see how long it stays up. And people like the first diabetic I showed you, his was clearly was still going up at 2 hours. And that may take more medication as well as diet. I think you can restore most of that beta cell function. And so you really know where you are on the spectrum, and we talked about the 10-year risk in Framingham. Most people are interested in their 20 and 30-year risk, sure, especially the young ones. And what both the calcium score does and the calcium scan and the Kraft test, it shows you when you're going to be at risk, literally 20, 30 years before you become diabetic, and you can have a heart attack before you're ever diabetic. Just like the calcium score becomes positive 20 years before you get to the threshold where you're likely to have a heart attack. And it's much easier to prevent when you diagnose early. And putting these two tests together, we really see both the bad prognosis and the good prognosis. People a little overweight,
true,
but are lucky.
So Arthur, just on this whole Kraft testing, and it seems interesting. And you've been a big advocate, and I've learned a lot on the intermittent fasting. Do you think that helps? That's number one. Secondly, there still remains a lot of resistance and skepticism about the low carb diet. Why?
I don't know. Now, if you look at the literature on low carb diets, excellent clinical trials, it's over 100 now. And I must say, in the early days of statins, I always remember I moderated a statin meeting, and at that point you were supposed to give a trial of a low-fat diet. So I was being politically correct. We showed a case of somebody with a high cholesterol. What are you supposed to do? They said, well, what would you do? I lied. I said I would start them on a low-fat diet, and the cardiologist practically rebelled in front of me. Their experience was it doesn't work. Most of them, if they've had experience with low carb, they know it works, and the clinical trials are there. Now, we use low carb, we will use keto, sometimes I call it keto friendly. The intermittent fasting we found to be the most helpful, because you're looking at these high insulin levels can take a long time to come down. Sure. And with intermittent fasting, with the insulin level falling, you get hungry because of certain hormonal changes, but those pass. The one that doesn't is persistently high insulin levels, where you drop your blood sugar, and that's when you will go crazy like the bears to eat. That's what you want to avoid. And with intermittent fasting, you're not hungry when you're intermittent fasting in general. And we found that to be one of the best approaches. But depending on the patient, we mix and match. But and the intermittent fast, there's so many ways to do intermittent fasting, and we vary it. With certain severe diabetics, we take them off insulin and put them on a several-day fast. We monitor them very carefully, and I've learned so much from Jason Fung, who taught us so much about fasting. And he says too, there are many different approaches, but very effective.
So again, Arthur, it reminds me and take me back literally to the time when we were seeing patients together and discussing almost on each case, and fantastic to do that again. I want to finish up with an interesting thought piece of yours. There still remains a lot of skepticism around the power of zero, and again, kudos to you. You've really taught me that. And when we started coming up with the idea of very high risk individuals, traditionally those with maybe LDLs 190 or more, of course, it was received with a lot of skepticism. And I can tell you, Arthur, that for folks who are watching out here, if you have to blame someone for that idea, that came from Arthur. When he showed me this list of more than 200, 300 patients he has been watching over the last 10 to 15 years with LDLs of 200s, 250, and multiple calcium score of 0. And that led to this whole curiosity of where it is. But in spite of the evidence, skepticism still remains. People are talking about, but what about that one exclusive non-calcified single lesion in one artery? Now, you've seen it all. Give us your final thoughts on this.
Yeah, the study which you've talked about, you don't have an atherosclerotic event with your first plaque, whether it looks soft and vulnerable or calcified. And I learned that from Bill Roberts, who showed you have diffuse atherosclerosis. That's why the calcium score works so well before you have an event. So just seeing a so-called vulnerable plaque in somebody with a low calcium score, the prognosis in studies is excellent. And in those with which I followed, people coming don't want to take a statin, we do the calcium score at 0. This is one of our examples. So this is very overweight with what's her total cholesterol is 330 and LDL is 250. Yeah. So this is as bad as you get. And you can see her particles are very large. She has a good HDL distribution. I think,
Yep.
whoops, can we go forward one?
Let's go ahead.
Oh, this is just showing the persistently really bad numbers. This is a very large LDL particles, but they're not atherosclerotic. This is a near normal Kraft test, no beta cell dysfunction, and no plaque in her heart. And we followed her. She's 64 now. I mean, we followed her for over 10 years.
And I've seen almost multiple patients you have followed for almost 15 years, multiple calcium score of 0, and really questioning the conventional dogma. Arthur, as always, I've learned so much. Definitely, this is a test worth investing further, and us trying to understand not only vulnerability, but as you've shown, resilience too out here. So, you know, as always, such a pleasure. We hope that we can get you back for us for a more discussion, and you could share more pearls of wisdom and your experiences. Thank you so much for coming again today to our studio.
I can't wait to return to this incredible campus, and it's just been a great day of learning. Thank you.
So thank you so much, everyone, for joining us at this late evening live from Cardiovascular Prevention series from DEBAKEY studio at Houston Methodist. Till next week. Thank you so much.